Welcome to Health Commune. I'm Dr. Smita, and we are going to speak about stroke, a conversation that can genuinely save someone's life, maybe yours or someone you love. My guest today is Dr. Muralidharan Vetrivel, a neurosurgeon and stroke specialist currently working at Rayla Hospital, Chennai. With over 14 years of experience across India and Europe, he has performed more than 2,000 complex neurological surgeries, including advanced endovascular interventions for stroke. Today, we are going to speak about stroke, how it is diagnosed, how it's treated, and how the treatment changed over the last 20 years. And there are a few things that still need to be changed. Stroke is one condition which doesn't give time to think. That's why this podcast is extremely important. So let's pay attention to what exactly Dr. Muralidharan is here to tell us. Good evening, doctor. Let's discuss about how actually we treat stroke now compared to what we used to treat before.
True. I mean, the problem and the way we diagnose stroke has changed, and the way we address the stroke has changed over years. There are two, three reasons for it. One is the diagnostic modality, what we have chosen, is definitely has changed. The next thing is the way how a physician sees the stroke is also changed. So, see, first to understand what stroke is. Stroke is nothing but a disease which is sudden in onset due to some sort of a vascular pathology to the brain. That means a blood vessel which is supplying a particular part of the brain is either ruptured or it's being closed.
Correct.
So the manifestation of stroke could be any functional disability. It could be a small speech disturbance that is happening, or it could be a small deviation in a part of a face, or it could be a weakness on one side of the body, or it could also be a sort of a numbness on one side of the body. So it depends upon which region of the brain is affected. Anything that affects their daily routine, from getting up from the bed, brushing teeth, wearing up the dress, eating food, walking, driving or writing, anything that is functionally affected, and if it's sudden in onset, it is a key indication to have a stroke. So the approach towards any patient who is suspected to have a stroke has changed based upon the timeline when we see the patient. So first thing is we want to know how many hours prior to visiting a hospital they were completely normal. So we want to know when were they seen completely normal in terms of without any functional disability. If we know that point, from there, if we are within 4.5 hours, the best modality to go ahead is to do a simple CT scan and then proceed with the CT angiogram in the same setting in an advanced center. If you are in a primary center where only a CT is available, then it's better to do a plain CT, rule out what it is, and then take it forward. If you're beyond 4.5 hours, the goal changes. Beyond 4.5 hours, we know that there is some sort of a irreversible injury that happens to the brain. So we are more interested in knowing how much amount of brain is permanently damaged and how much amount of brain tissue is salvageable. So beyond 4.5 hours, we tend to do an MR imaging with a very limited sequence, because MR is usually a time-consuming modality, because you need to put in and the machine has to do various sequences to come to a conclusion. Not like CT, just few seconds inside and you get the entire panel. And if we have someone who has come to us beyond 12 hours, or whom we know that there is a large amount of tissue which is salvageable, but still there is something which is dead, we do something in advanced imaging called MR perfusion imaging. This is exactly correlates with the amount of blood that goes into every gram of tissue in the brain. So this indirectly tells us few things. One, how much the blood is going into the region which we are interested in the brain. How long does the blood take to exit the brain from that particular region? And how long does it take to reach the peak flow and then go down?
Correct.
So these informations gives us an idea whether the tissue is dead, is it at risk, is it salvageable or not. See, ultimately what happens is the capacity of the institute where you are visiting. So if you don't find any center which has a MRI within few hours of your home, or few minutes from your home, it's better to go ahead with CT and ensure that you reach the definitive treatment place as early as possible, rather than wasting time. That's what happens. So it's very important. Every household or every individual knows where is their comprehensive stroke center, where is the diagnostic modality available within their home, because time matters.
Correct.
Okay, so whatever decision I told, it's entirely dependent upon the time. I did not say anything else except for the time. So I think it should be everyone remembers the phone number in those days. It's important you know where your comprehensive stroke center is from your home. So this is the complete different change.
So people do this, like they go to the nearby hospital, get some investigations done over there, then they get referred to the center where the stroke specialized care is available. So what you are suggesting is you should have that prior information where the stroke
Correct.
management is there, have that emergency number with you. Whenever any such kind of a thing, reach to the right hospital on right time.
That's right. That's right. Yeah, perfectly put. Because see, what happens is as you start jumping from one center to the other center, you're losing time, and every minute or every second you lose, there is billion of neurons that is going to be dead,
True.
and the tissue which is at risk is going to get increased, and the tissue that is permanently damaged is going to get increased. The capability for any neurointerventionist or a neurologist or neurosurgeons to salvage the brain tissue becomes small. So the idea is to provide the expertise as close to the patient as possible. So don't jump centers if you have a stroke. It's better you go to one center and finish it.
Got it. Usually, we just go to Google, we search which one is the nearest center. Is there any way to find out like where to actually go in case of stroke, or just randomly search on the Google and deep dives research? Is there any way?
So you generally any region in the state should have a hub center. That means that's a center which is completely equipped and capable to handle a complex problem of the stroke, irrespective of end to end. Okay? And there will be small spoke centers. So it's very important the centers get integrated with each other. So nowadays, how generally in practice happens is there is always a family physician or physician whom they regularly visit for a diabetes or a hypertension management. So they generally know which is the closest center which can provide a comprehensive unit.
Correct.
So it is important you inform your family physician that you are high risk for a stroke. For example, you have a cardiac disease or a valvular disease, you had a diabetes for a long time, you have a hypertension for a long time. It's important that you have this sort of a discussion with your family physician in case at this emergency point, what should I do? Where should I go? So that discussion should start happening at an early phase
Got it.
once you have an association with the family physician.
My next question is like, I agree now with the diagnosis, though equipment and all we all know, but the approach towards managing stroke has changed. Physicians are looking at how they can protect as much as part of the brain. And that's why the diagnosis modalities are changing. And that's so beautifully you have explained. Now, because we diagnose it differently, do we also treat differently? How it is different from how it was probably 20 years back?
See, those days we didn't have much of a technological advancement in terms of devices to reach the brain where the clot is. Like how they do it in the heart. You have a block, you go there, you put a balloon or open it up, or you put a stent and come out. Okay, that technology was not there to do it inside the brain, which has completely changed in these days, and it's more accessible in India than what it was 20 years before.
Yeah.
Okay. So the idea for any treating physician handling stroke is first to identify whether there is a vessel that is closed or whether cell that is ruptured. Okay, let's discuss only about the vessel that is closed. Okay, the idea is when the vessel is closed, we need to open it as early as possible so that we can save the tissue in large areas so that the functionality is preserved. So what we generally do is we try to see is there a occlusion or a narrowing in the blood vessel which starts all the way from the heart up to the brain. Okay, it's not just within the brain. You can have a stroke by having a stenosis at the arch of aorta, just at the origin of an ICA. You can have a infarct with a stenosis in the neck in the proximal ICA. You need not have a large vessel occlusion inside. It could be just a flow dynamic change which can result in an infarct. So to know that we do this, all those imagings which you have done. Second is we have to be sure whether reopening that vasculature will be productive for the patient or not. For example, if the dead tissue quantity is very high and you're trying to reopen the entire vasculature, what is going to happen is a dead tissue suddenly perfused is going to bleed inside, which is going to be detrimental. That's why we do all this advanced imaging to take that call. And once we do that, we decide on starting medications like how it was before. Probably they were using Alteplase before, but now the trend is moved towards Tenecteplase. The reason is it's more easy to administer. If you're giving an Alteplase, you have to give a bolus dose, wait for some time, and then put on a drip and then observe it. Whereas Tenecteplase is quick. We just need to give a single dose, more easy to administer, and as immediately as diagnosed on the gantry of an MRI CT, you can give it off. So this goes and bursts the clots as much as possible. And the second thing is you need to go and take the clot. It's not 100% that once you give the injection, the clot gets sliced. You have to remove the clot. So we proceed with something called a mechanical thrombectomy. So mechanical thrombectomy is nothing but a procedure where we try to reach the region of occlusion either in the neck or inside the skull, which is a primary feeder for the brain. So, which usually is done through a small puncture from the thigh by passing a series of tubes across the heart, ascending up, and then we try to aspirate it. We have special aspiration catheters which can take all the turns inside the skull and suck the clot. If the clot is becoming very long and relatively harder, which we have some certain characteristics in MRI to pick it up, we use something called a stent retriever. Stent retriever is nothing but a mesh of metal which will hug the clot and try to pull it out. So these are the two things which we generally do. We call it as an aspiration thrombectomy or a stent retriever based thrombectomy. We can also combine these procedures to do it, which is quite different from what we do in the heart. What they generally do in the heart is you put a balloon and open it up, right? Here we don't do that. We don't do that in most of the cases. It's only to remove the clot as much as possible.
Okay. When we speak about rehabilitation or when we speak about physiotherapy, is there any change in the way we approach now?
Definitely. See, the more you save, the more better the functional outcome is. So if you want to save more part of the brain, you have to be more early to the center. So ultimately what has happened is since the incidence of thrombectomies have increased in recent years, the functional disability what the patient lives with has significantly come down. And the mortality, usually you have two sorts of mortality issues during the stroke. One that happens within the period of admission, which was common in those days. Because if you have a large IC occlusion, the brain swells up and then it gets shifted, there is a death. Second set of problems is patients who have a chronic disability like one-sided hemiplegia, bedbound, they start developing pneumonia and they have urinary tract infection and then they die beyond the 30 days time. That is outside the hospital. By these recent advances, the first set of mortalities has significantly gone down. Okay. But the second set, where there are still a subset of people where either they are not able to access this sort of healthcare, or where the delivery of this particular intervention can be lethal, where those people are left with a deficit, they need a continuum of care. There is a huge role for occupational therapists, physiotherapists, PMR physicians, and some social workers to first increase their capability to handle their functionalities. Second, to identify and deploy them in some sort of a vocational training and other rehabilitations. But definitely those things has changed. You wouldn't have heard of an occupational therapist 25 years back, I'm sure about it. You wouldn't have heard of a PMR physician actively involving in stroke rehabilitation. All those things has changed in recent years. The continuum of care matters a lot, and that has a huge impact in the mortality.
Do we now monitor patient differently? Like how many follow-ups do we need to do? Are there investigations we are asking patient to do it after the stroke or after the recovery, which was not done before? And with probably the technology, we are trying to monitor it more closely to prevent complications or to prevent second stroke. Are there any changes in that aspect?
Yeah, definitely. See, stroke is just a sequelae of the systemic disease what we are having. Either it's going to be a chronic hypertension or a diabetes or a hyperlipidemic status or a secondary to a cardiovascular status. So once you have a stroke, there is definitely so many times increase in the potential of having a second stroke. So addressing the risk factors becomes highly important. So it is mandatory that we have a proper schedule of follow-up. So what generally I practice is we post-discharge, we follow up them after 7 days, 1 month, 3 months, 6 months. This follow-up is important because, as I told you, they may land up with a second stroke during this period. They may be left with some sort of a disability which can lead to a lethal problem. Third is we need to address the primary problem. For example, there is a valve replacement that is being done. and there is a mitral valve vegetation which is throwing up a stroke. You would have treated the stroke, but the primary disease is in the heart, which needs to be addressed. If you don't address it, again the problem is going to recur. If you have a chronic hypertension and you're not managing the blood pressure well, and if you're not managing the sugars well, you have proximal ICS stenosis, and that left unaddressed, obviously there is going to recur the stroke. So it becomes mandatory for any patient to be on a regular follow-up once they have a stroke. There is, it's not like you have a fever, take a medicine, go back, fever is gone. It's not that. There is a mandatory follow at least 7 days, 1 month, 3 months, 6 months. The standard practice what I do.
And because of change in the way we diagnose, we treat, we monitor, do we see better results now? And if yes, in terms of what? In terms of mortality or disability, what are we able to better for patients and their families?
Yeah, there is significant impact in the mortality that I would say, because someone who's having an ICA occlusion 15 years back, I'm not sure whether they would have had an aspiration catheter to remove the clot. It was not available in India, but today it's available and they can walk back home. Someone having a basilar thrombosis is 100% mortality there. At the max, what you can do is do a thrombolysis if they come within the window period, and then you proceed. But nowadays, you have lots of devices which can remove the clot, and that has a huge impact in the mortality. People increase their survival. Second, in terms of disability, we have not cracked it completely, I would say, because if we have an occlusion beyond the M2 segment, probably in the more distal part of the vessel, we have not come up with a device to remove those things more easily. And those patients still need some sort of a continuum of care and supportive therapy from occupational therapists, physiotherapists, and PMF physicians. And the biggest challenge, what I have seen compared to the European practice, is we have seen lots of patients with atherosclerotic disease, primarily involving the intracranial vessels, which is a very large subset, I would say. It is not a pure clot. So these set of patients who undergo thrombectomy might require some sort of a stenting in the same setting or in a later phase. And they are very prone to have reocclusions within 48 hours to 70 hours after the thrombectomy. And I think it's a genetic predisposition which has led our population to have a stroke at least a decade here earlier.
Yeah.
You see a stroke in 75 year, 80 year there. You see a stroke here in 45 years, which is, your functionality is completely gone. So that is something which the industry has to crack, not just the doctors. That is something challenging which we are not solved yet.
Okay. Now we know that in 2026, the new guideline for stroke management is there. Do you see that in tier 2 cities or across India, all the doctors are adopting these newer methods of managing stroke? Patient is not staying very near to the advanced care center always, right?
True.
Patients are everywhere. Stroke can happen to anyone, anywhere. So are doctors aware about it? Is there a better adaptation amongst doctor for the newer modalities? What's your experience in that?
Definitely, there is a huge gap that needs to be filled, especially when you go to the tier 2 suburban areas. The accessibility of diagnostic modality becomes a challenge. Okay, you may be in the prime city, you may have an access. If you go to a tier 2 city, if you're staying at least some 30 kilometers away from the city, you lose completely the initial golden hours where you need to go and do a diagnosis. And once you do the diagnosis, where are you going to go and get the treatment? Okay, so you need to have an advanced imaging to understand the problem, and then capability with a physician or an interventionist who's trained to do a thrombectomy. There's still a huge gap. The reason is not because doctors are not trained. It's a very capital intensive process. Putting up a MRI machine in a suburban place, do you think it's functionally viable, financially viable? It's not possible. And you cannot afford a material which is being imported from outside Indian market and being used for thrombectomy, which is going to cost you a few thousand euros or dollars, which again talks about besides the accessibility, the affordability.
Yeah.
So that is a huge problem.
We don't have the products in India.
So there are lots of companies which have started manufacturing. We have a couple of companies, one based out of Hyderabad and another based out of Bangalore, which is in Gujarat as well, where they are trying to come up with these devices which is indigenously made, with technological transfer from the West. But still, we have not cracked out the problem completely because the raw materials again is involved in terms of the global situation. But I would say the cost which was involved in thrombectomy from 4.5 lakhs to 6.5 lakhs between whichever hospital you are can be brought down to close to 2.5 lakhs, which can be reasonably affordable. I mean, you're bringing down by 30-40% is a significant amount to, make it affordable. But still, it's not accessible to many parts of the world.
Correct.
Within a country.
Correct. But is it covered under insurance?
Yeah, definitely. Most of the insurance covers it. But the problem is, see, when you have a comorbid illness, your risk of having a stroke increases. You had a valve replacement under insurance. You are the person who are going to have a stroke. You are the person who was supposed to be covered by a policy for a thrombectomy. But in reality, the moment you have a heart surgery, your insurance premium either goes up or the insurance company says you're already having this comorbid illness, you're not fit to avail this thing. But there are some government insurances which again provide some funds. But again, I told you it's 4.5 lakhs for one thrombectomy. The government insurance of 5 lakhs for the family.
Yeah.
There's a huge mismatch in what we are dealing with.
Correct. So what's the way out for patients, those who are living in the remote areas? And, I feel that we are no more that country where extreme poverty is there. I agree it's there, but there are people, those who are staying in the little remote area, not very close to metro cities. They are doing good business. They can afford things in life, even if it is not covered in under insurance. But the infrastructure and facility is not there. So what's the way out for them?
See, the first thing is, I would say prevention is the best thing that
Always.
curing this problem. Okay, so lifestyle modification, good control of the comorbidities, having a periodic health checkup. These gives you a significant reduction in the risk of having a stroke.
Correct.
I think this decreases the total burden of the cost in the healthcare. Okay, if you do it in a very proper, systematic way for all this non-communicable diseases. For someone who is staying outside, it's still challenging. We have lots of logistical challenges. See, you take a person who's staying in a village nearby, take a city like Chennai, a village nearby Chennai. For them to reach Chennai, it's going to take time, correct? And the person who's living in the village is only going to reach the general physician whom they have trusted as family physician for a long time, correct? And even if he conveys them the information that you have to go directly there, it's a human tendency to go to someone whom you rely on. Okay, so this ground level education is what that matters. So, which I don't think can be done by doctors. It should be done by lots of social communities and NGOs who raise the awareness for the people to reach to the center, which is more helpful for them rather than going to someone whom you're trusting in. Definitely, you can trust them. They will also say you go to this place to get it done, but you lose time. It's like you have an accident, you go to the nearby hospital. You don't go to the hospital which you know for 10 years. So it's a reverse problem here. The problem here is you have to go to the center which is capable, not to the center which is very nearby, which is not capable.
Correct. And you talk about the prevention, also the annual checkup. What are the things that a person can do during their annual checkup to identify whether they come in the risk zone, and they can do some lifestyle changes and preventive measures that if they can take?
So first comes to the lifestyle. One who doesn't have a proper workout schedule, who's stuck to the computers and digital systems, predominantly about sedentary lifestyle on junk foods, or extremely high risk to have a stroke. Second, you have a comorbidity or a familial history of having a diabetes, hypertension, or hypercholesterolemia. You are highly prone to have a stroke. So it is important that when you go for a routine mast cell checkup, you check your blood sugars, you check your blood pressures, check your fasting lipid profiles. We recently in our institution, we have added up a carotid Doppler and vertebral Doppler for all the patients with health checkup who are undergoing a family health checkup, because we find that they stay asymptomatic even having an arthroma and an ICA.
Yeah.
They become symptomatic only when they have some sort of a sudden dehydration or sudden diarrhea episode, sudden fever. They suddenly have a stroke. The problem is they have an underlying stenosis, and during these episodes, they'll lose the volume and they develop a stroke.
Correct.
So we have brought in this carotid Doppler and vertebral Doppler along with their fasting lipid profiles and diabetes hypertension screening, which is something which we feel we could pick up the vascular disease much earlier than what it is.
Got it.
Second is doing a routine echo, especially when you are above 60 years of age, being a diabetic for more than 5 years or a hypertensive for more than 5 years. And if you're very poorly compliant with medications, definitely we tend to do an echo as a routine. And these are things we generally do in terms of screening to identify a vascular pathology inside the brain much earlier.
Got it. And my last question is about the neuroprotective drugs. How much of the place that neuroprotective drugs hold in the stroke management? What are the practices in India versus Western countries?
You want a real answer or a market-driven answer?
I need a real answer for sure.
All right, okay. See, most of these drugs, what is neuroprotection? See, the cell is dead. You cannot reverse the cell to grow back. There is no role for it. Only thing what the drug can do is the amount of oxidative stress that cell undergoes can be reduced. The amount of free radicals that is getting formed can be reduced. Because the cell membrane is made of acetylcholine, you cannot put a acetylcholine molecule inside to reverse it. It's not going to happen. Okay, or else there'll be a stem cell which can be put inside and say the cell is regenerating. It's not possible. What we are addressing with the medications is to decrease the oxidative stress in the region which is at risk and it's not dead. Okay, but that doesn't equate to a functional outcome. That's something which people misunderstand lots of the time. A dead tissue can cause a symptom. And tissue at risk can also cause a symptom. Okay, a weakness can be because a cell is dead. A weakness can be because the cell is being suffered because of low blood flow. You can only cure those patients who have a low blood flow. You cannot cure a patient who is having a dead cell. Let's be clear on whatever molecule you find out that cannot be reversed. Okay, so there are medicines. Alteplase is one recent molecule pushed by the market into it to say that there is increased amount of functional independency, but the functional independency depends upon the region of the brain, not on the size of the infarct. You can have a large infarct in the front part of the brain and you can be completely asymptomatic. Okay, you can have a small 1 millimeter of infarct in your internal capsule and you can become completely hemiplegic.
Yes.
Okay, but this is a wrong perception what people are being driven into saying. You have a small infarct, you don't need to worry, but you can be very worrisome with having a small infarct in the pons. Think of an infarct somewhere in the pons and your swallowing is gone and your face is gone. You are functionally disabled, aren't you? Yeah. You can have a large watershed infarct in your parieto-occipital region. Unless you are a pilot or a neurosurgeon or someone working under the microscope, you are functionally perfect.
Yes.
I think certain things are completely market-driven. The market can go against me, but some things are perfectly market-driven. But there are definitely drugs which can decrease the oxidative stress in the tissue which is at risk, but it cannot reverse a dead tissue. Let's be very clear on that.
Perfect.
Whatever pharma company pushes in the market, it's not going to help a dead tissue. You cannot reverse the dead tissue.
And that was Dr. Muralidharan, and we talked about stroke. Please share this with someone who has a family history of stroke or who's currently taking medications for hypertension or hypercholesteremia or high lipid profile. Don't forget to subscribe. I'm Dr. Smita and you're listening to Health Commune. Real doctors, real answers.